Okay, so so today we start with pharmacogenomics. Okay, this is a new word. So pharmacogenomics is abbreviated by PGX. Okay, and this is a very important concept. Okay, so 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 when you talk about pharmacology, we all know pharmacology. Okay, so pharmacology has many components within it. So one is pharmacodynamics, which we briefly saw yesterday, and we are going to see it more today. So pharmacodynamics, in very simple words, is what does the drug do to our body. That means if you take a drug, where is it going, where is it binding, what it is doing, is it reducing the disease, right? So it is mechanism of action, drug receptor interaction. What is a drug actually doing in our body? Pharmacokinetics is what the body is doing to the drug. Okay, so that means, have you guys heard of ADME, right? So, oh, you guys are pharmaceutical students, many of you are, right? You are. So yeah, of course you know this thing very well. And this is pharmacogenomics. So this is a very different concept. And we will focus on this today. And toxicology, you know, right? For every drug, we have to do toxicology studies to see whether it is toxic or not. And then finally, it is clinical pharmacology. So let's see, what is PGX? So when you look PGX in literature, it is very confusing because people do not understand the actual meaning of PGX, so they have included many things. So I'm going to tell you exactly what is classical PGX. Okay, so PGX, this pharmacogenomics is made of two words, pharmacology and genomics. You combine. So anytime you have the omic word in the end, what does it tell you? If it is genomics versus genetics, right? If it is proteomics or omic, any omic, what does it tell you? Metabolomic, what does omic tell you? What is the meaning of omic? It is global. You are looking across the whole thing. If you are working with a cell line, you are looking at all the proteins in the cell line. If you are working with the organism, everything within that organism, right? So it is genomics and pharmacology, which together makes pharmacogenomics. Now pay attention to this word. PGX is the field that studies how a person's genetic makeup affects their response to medication. So this is what I was telling you yesterday. Suppose there are 10 patients, okay, identical disease, identical TNM staging. So exactly the same set of disease, same aggressiveness, everything. But depending on their genetic makeup, if we give them the exact same drug, they will respond differently. Okay, that is pharmacogenetics. That is pharmacogenomics. So different people respond very differently to the same drug based on their genetics. And this genetics is the germline genetics, not the tumor genetics, something we are born with. Okay, so genetic variants can influence 4 things. Drug metabolism, that means how fast the drug is metabolized in our body. Drug transporters, so some people express more drug transporters, so they throw the drug out of the cell. Okay, risk of toxicity and likelihood of benefit. So these are the 4 things. So what that means, we are going to go into detail with real examples. So what PGX enables, it allows you to choose the right drug. Equally important, the right dosage. So you may need more dose than I do, and vice versa. Okay, so right dose for the right patient at the right time. Okay, so by that you can actually save people's life, because sometimes the side effects are so severe. Okay, personalized medication dosing, choosing the most effective drug, and it is extremely powerful, not only in oncology but many different other diseases. Okay, so what is the difference between pharmacogenomics and precision medicine? Okay, so pharmacogenomics focuses on drugs response. Precision medicine will look at the disease and find the right therapy. It is drug response exactly or the drug dose, those things come under pharmacogenomics. Precision medicine will always look at the germline mutation plus the somatic mutation, especially the tumor one, right? If the tumor is expressing HER2, they are going to sequence it to see if HER2 is there, right? So really focusing on the tumor as well as the germline, BRCA1, BRCA2 deletion, right? Germline. So precision medicine will look at both kinds of mutations. Yes, go ahead. Somatic means anything which is out of germline. So germline mutations are present in every cell of our body, right? You know that. And somatic mutations are something we acquire. So tumor cells acquire mutation. So for example, HER2 is overexpressed. Exactly. So that is somatic. But if it was BRCA1, BRCA2 deficient, germline, right? So there are both kinds of it, and then you start giving the drug and the tumors will now acquire even more mutations, right? It's a constant fight. So precision medicine has to take both into account, but PGX only looks at germline genetics, okay? Now this one is mainly focused on pharmacology of the drug. This is broader biology, as you see. Precision medicine looks at the whole thing. This example I will show you today, this is a very famous example, and precision medicine HER2 is a very good example. HER2 is overexpressed, you give HER2 antibody. If HER2 is not overexpressed, why would you give HER2 antibody, right? So this PGX enables personalized, safer and more effective drug therapy, okay? So let's look at the different things which PGX allows us to do. So PGX studies how a person's genetic makeup affects their response to drugs, including efficacy, toxicity and optimal dose. So safer drug prescribing. So I will tell you this in details. I told you yesterday, just a little bit here. So abacavir, this is a drug. So if the people have mutation in this gene, they become hypersensitive to abacavir. This is a HIV drug, okay? So they cannot take the drug just because they have this mutation. Now this has nothing to do with HIV itself, but it has to do with drug, how it metabolizes the drug, and because of that they cannot take it, okay? So now in this case, warfarin is a drug. People who have mutations in this thing, they have to be closely monitored for the dose. Again, I will tell you all of these in details. Okay, they are antidepressants. You have to do genetic testing of CYP2D6 before you give those antidepressants, because it will work in one person and the other person will go crazy with the antidepressant because of the drug metabolism. Okay, so PGX can also tell you whether a drug will work or not work. Okay, so I will show you all of these things with examples. So if you, when implemented universally, so many times, you know, the technician who is, or the doctor who is prescribing the drug, they just go and they feel like, okay, we should give you this drug, 75 mg, this and that, without like everyone who comes to their door, 75 mg, that's very wrong. They actually have to do the testing, okay? Not for all drugs, for many drugs, okay? Because the drug can have extremely severe effect and the drug itself can kill the patient, okay? It is that serious, okay? So this is patient with same diagnosis but treated with same medication. These people had good response, they had partial response, they had no response, and they actually had extremely adverse response, and that is what is defined by PGX. So yesterday we spent a lot of time on health disparity. So this is how we address pharmacogenomics, how pharmacogenomics reduces health disparities. Okay, so why disparities exist without PGX? Again, it depends on the doctor or the technician who is prescribing. So they are just saying, oh, 75 mg worked for her, so let's prescribe the same thing. So, so drug metabolism genes vary by ancestry. So for example, Asians will metabolize the drug differently than compared to Caucasians, but within Asia also, different people from different countries may have completely different metabolic profile for the same drug. So drug metabolism genes vary by ancestry. This is a very prevalent thing. Okay, clinical trials overrepresent European populations. So most of the things clinical trials say or FDA approved, most of them are Caucasian people. Okay, people low ethnic, like trial and error prescribing harms to racial ethnic minorities, they were never included in clinical trials. So nobody knows exactly how the drug is going to work. Our patient, go ahead.
I have a question. So in the modern drug discovery program, so all these prescriptions vary for different patients, different ages. But traditionally, maybe long ago, so in other medicines like Ayurveda, Siddha, Unani, and all those traditional medicines, so do they also had such kind of dosages for different ages?
So Ayurvedic medicine and homeopathic medicines, I don't know much about homeopathic, but Ayurvedic for certain, those things are not harmful for us. Okay, these allopathic medicines can be very harmful for us. Actually, I did not know, I reacted myself very strongly against some medicines. Okay, so I did not tell you the whole story yesterday. So codeine, you know, people get addicted to codeine. And I had a surgeon, I was given codeine 2-3 different times in my lifetime, and I was throwing up. Like I could not take codeine. I could take the pain, but I could not take codeine. And on the other hand, 90% people get addicted to codeine. They cannot live without codeine. So obviously my metabolism is different than theirs. And while I was preparing, some other drugs came, which I also have taken, and I had very severe reaction. So apparently my metabolic pathway is different than most of them. To your question, Ayurvedic, I don't think they are harmful. They are pretty natural remedies. So they are not likely to have this effect. Now keep in mind, not all drugs require this testing. So right now there are 30 genes panel that they test for the drugs. Okay. If you want to do extensive, you can go up to 100, but that is all right now. But most of the time it is 25 to 30 genes are there, and the metabolism can really change the drug response. Now, there are very famous medicines for them, for statins, for example, right? If a particular statin is given for high blood pressure, they have to do the genetic testing, otherwise the person will die. You know, and hypertension medicine is so common, right? So, but I think Ayurvedic is pretty safe thing. What do you think about it?
Yes.
I think Ayurvedic is very natural and very safe. Allopathic medicines are the ones with the most side effects. Okay. So drug metabolism vary by ancestry. So it is all about the genetic. Okay. So, and those populations which are underrepresented are more likely to be harmed. Okay. So how PGX reduces disparity? So old model was that you look at the race, body weight, guesswork, give the medicine. The PGX model is that you actually do the testing. And it is a very easy testing. People just test, I mean the doctors are supposed to check 25 to 30 genes all together, okay? And you can give exactly the correct drug at the correct dose. So it eliminates bias and stereotyping. So why PGX is uniquely powerful for equity? This is very important because every person is different here, and that is why it is very important to do the genetic testing. So germline based, stable across life. Once you know you have the gene, right? And preemptive prevents harm before it happens. You will see in some example that it is extremely severe reaction for very simple medicines, okay? Universal testing avoids selective access, action level clear, clinical decisions. So PGX reduces health disparities by replacing trial and error and social assumptions, okay, with actual genetic evidence, okay. So there are two genomes to consider, right? There are two genomes. One is germline, something we are born with, and then there is this tumor genome, okay. Tumor genome is extremely important to find the right therapy, correct? So tumor genomes includes both inherited mutations and acquired mutations that are specific to the cancer cells. So these mutations can make a cancer more susceptible or resistant to specific targeted therapies, right? Germline is the patient's inherited DNA, and actually it is our germline DNA which decides how the drug is metabolized in our system, okay. So this part I have made it in red, and there is a reason for that, because half of the papers you will read about PGX, they will also include targeted therapy in the PGX umbrella, okay. So do you think targeted therapy should be within PGX? So think about it for a minute and tell me. So suppose somebody has cancer, right? And yesterday we went through the exercise that you guys are oncologists and somebody comes to you. So what are the steps you are going to do to figure out the therapy, right? So targeted therapy comes at what stage? You guys are going to look at the tumor and see what is wrong with that particular patient after biopsy, correct? And then suppose you find that RAF is mutated, V600E, the famous RAF mutation, then you will give the drug for that mutation, right? So should this come under PGX umbrella? Think about it for a minute. So suppose someone with breast cancer is overexpressing HER2, or somebody with lung cancer is overexpressing EGFR receptor, right, or mutated EGFR receptor. Is this a PGX decision? Yeah.
It is not, because it's not a germline.
Because it is not a germline, right? So I found many talks about PGX where they have included this in PGX. It is not PGX because it is not germline, because you're talking about the tumor mutations there. However, if the tumor has BRCA1, BRCA2, and every cell of the body also has BRCA1, BRCA2, then it is PGX, right? Okay, so that is why I made this red. I was going to delete it, but then I made it red to ask you guys, do you think this is PGX? It is not PGX, unless these mutations were inherited from the parents, then it becomes PGX, okay? So these mutations are somatic mutations. It does not involve germline genetic variation. It does not predict drug metabolism or toxicity in the patient. Having HER2 doesn't tell you anything about the drug metabolism. Go ahead.
Ma'am, it doesn't really take in the toxicity studies of how the therapy would
Nothing. It is just targeted therapy. So this is precision medicine, but this is not pharmacogenomics, right? So you guys have a clear understanding between the two, right? So germline genome is something we are born with. It is inherited. It will not change over time, okay? And PGX test variants in the genome predict drug metabolism, toxicity, and response. PGX does not primarily use somatic genome. So keep in mind, when you go back and you look online, you will see people have included somatic mutations. That is not PGX. Okay, they have made that, they have made this umbrella, they have added it there, but it is not. Okay, so PGX is germline, tumor genomics is somatic mutation. This is inherited DNA, this is tumor DNA. This is, look at the things it is doing. Main goal is the right dose to predict toxicity before you give it and efficacy before you give it. This is allowing you to select the drug. HER2, you accordingly select the drug. Okay, this is here. Pharmacokinetics and pharmacodynamic, they are very important. I am going to tell you about that. And here only pharmacodynamic, and these are the examples. Okay, so I will give you the examples in great details with their functions. So this is the simple comparison. So this is germline. Every cell of our body has a mutation. So if you have to test, you just take the saliva, because every cell, including our saliva, has it, right? Here you have to go to the tumor tissue to do a biopsy. Makes sense? Lifelong, this is when the disease is there, that's when it is there. Drug response, this is tumor biology. So now you guys understand. So this is, so look at this. I've already told you about this, right? So these are PGX germline, and this is tumor genomics here, okay? And the key difference also we discussed. Now let's look at some real examples. So this is what I was telling Venkatesh, that usually they test very few genes. They can only test these many genes, and they don't have to test it for like several medications. They know they are safe. But for many, they have to test before they can prescribe. They should not prescribe for many. So core clinical PGX are 15 to 20 genes, and doing a PCR of 50 to 20 genes is a piece of cake. Most clinical PGX panels include 20 to 30 genes. If somebody really wants to do a real extensive one, it's 50 to 100 genes. Okay, especially if you're really going after something, some really novel drug, then probably it is a good idea. Okay, so this is tumor genome, this is the germline genome. Okay, so let me briefly tell you about pharmacokinetics and pharmacodynamics. So pharmacokinetics and pharmacodynamics, like I said here, okay, in this one, where did I say here? Here, in germline, in PGX, these two things are very important. So I will tell this again in the next lecture, but very briefly, pharmacokinetics is what the body does to the drug, okay, how quickly it is metabolized, whether it is absorbed, how it is distributed, how quickly it is excreted from the body. The whole ADME panel is pharmacokinetics, and it makes sense. This comes under PGX umbrella. And pharmacodynamics is what the drug is doing to the body. Okay, so target binding, biological effect, clinical response, that is all pharmacodynamic. Okay, so germline genome actually determines the pharmacokinetics, pharmacodynamic, and finally the clinical outcome. So the variants, because of that, pharmacokinetics will be altered because the drug levels will be altered. So it's very simple. If a drug is metabolized very fast, the levels are going to be low. If the drug is metabolized very slow, it is going to be high. Very simple. So if I have an enzyme which will metabolize it fast, drug will not stay. So I have to be given higher dose. But if it is not metabolized in someone else's body, they have to be given lower dose. Now suppose I take a statin, right? And that statin is supposed to go to the liver, and I have a mutation in a gene in the liver, so the statin doesn't go to the liver. So what will happen? Statin will circulate in the blood because liver is not able to take. So when the levels of this drug gets very high in the blood, so the doctor will say, oh, give her more statin. But the thing is that forget about giving more statin. Whatever statin I have taken, the regular amount, that is accumulating in my blood because liver is not able to take it. So that itself will kill me. Forget about increased dose there. So that could be actually fatal. So it's very important that if you're aware of these kind of things, you have to do the testing before you give the drug. Okay. So, this is genetic variation in drug metabolism enzymes. We don't have to do 1,000 genes. We know the key genes, key proteins which are involved in drug metabolism, and these are some of them. So these CYP2D6 determines whether metabolism is going to be fast or slow. This determines poor metabolism, drug failure. If this is not working, poor metabolism, drug fails. We take it, it is not useful in our body. This one determines the clearance in the body. So let's go to the actual examples here. So before I go to the actual examples, so how pharmacogenomics personalizes cancer treatment, it helps in optimizing drug dose, which makes sense. If drug is metabolized, I is missing here, sorry. If a drug is metabolized too slowly, it can build up to toxic levels causing severe side effects. If a drug is metabolized too quickly, it will be cleared from the body before it can have a therapeutic effect. predict and minimize toxic side effects, obviously, right? And you can tailor it exactly to the person, okay, the person's genetics. All right. Oh, did you take the picture? Should I go back? Should I go back? You took it. Very good. Okay. This is now, let's look at the real example. Okay, you will get all of these things tonight. I did not, today again the internet was jumping around, so I could not send it to you because it was on and off, but it was just temporarily, so it's not a problem. Okay, so let's now look at real example. Okay, so what happens is that in blood cancer, in leukemia, these drugs are given. It's very simple. 6-mercaptopurine, azathioprine. So this is azathioprine. This is 6-thioguanine. 6-thioguanine. This is 6-thioguanine, and this is 6-mercaptopurine. Okay, so you can see this is purine, and if you put NH2 group, it becomes guanine. Okay, and this is azat. So these drugs are given to leukemia patients, but they do not work. If you give it, it is not going to work directly. They are further metabolized in our body before they become actually a drug. Okay, so after administration, these three drugs have to be metabolized to become active. Basically, you make the triphosphate of this thing: monophosphate, diphosphate, triphosphate, just like ATP, GTP, UTP, TTP, right? So when they say metabolize, you are actually making the triphosphate. So in AML, mercaptopurine is the primary thiopurine used. Okay, so mercaptopurine after administration is converted to the corresponding mercaptopurine triphosphate, just like ATP. Okay, so this one, so they call it TGNs, triguanosine nucleotide triphosphate, causes DNA damage in cell death, which has the desired therapeutic effect. So one of the ways to kill the cells is that instead of, so you know all DNAs, they need ATP, GTP, TTP and CTP, right? No UTP. UTPs are for RNAs, right? So they need that. So you could, so adenine ring and guanine ring, right? So what is the substitution in adenine? NH2 group, right? If you have a purine ring, if you put NH2 at the C6 position, that is ATP. If you put NH2 at the second position and ketone there, it becomes guanine. So look at the structure here. So if you normal case, you will look at this structure here. It will, if you, this is O and this is NH2. So all you replace S with O, it becomes guanine, right? It is thio-GTP basically. So this is, if you attach the sugar, it will, and phosphorylate, it will mimic GTP, except it is thio. This is purine. So here you have NH2 group in the case of adenine. So basically the point here is that when you give these things and when they are converted to the corresponding triphosphate, DNA polymerase can mistakenly add this in the DNA thing, and then the DNA will be damaged and basically the cells will die. That is the point of giving these drugs. Okay, so let's see what happens. So when we give these drugs, when we give azat, it is converted to 6-MP, 6-mercaptopurine, or we can directly give 6-mercaptopurine. And 6-thioguanine. So then what happens inside the cell? There are these, do you guys know which kinase phosphorates the purines to the corresponding monophosphate? Have you read that? Probably not read it so far. So there is, so suppose you have guanine, then there is, suppose you have guanosine, because you have to attach guanine to the sugar before it can get phosphorylated, right? So guanosine is phosphorylated to GMP by guanylate kinase. Adenosine is phosphorylated to AMP by adenylate kinase. Cytidine is phosphorylated to the corresponding CMP by cytidylate kinase. Thymidine is phosphorylated to TMP via thymidylate kinase, right? So these guys are phosphorylated now. Okay, so this is such a small difference between GMP and thio-GMP that the guanylate kinase will convert 6-TG once the sugar is attached to 6-thio-GMP. GMP will be converted to GDP, GDP will be converted to GTP. Okay. Now once this is my mistake, I said something wrong here. Guanylate kinase comes here, GMP to GDP, not from this to this, my mistake. So guanylate kinase will be here. This is attached to the sugar with the phosphate directly. Okay, that is not relevant to you, but I want to be completely accurate. When you go to monophosphate to diphosphate, that's when the guanylate, cytidylate, adenylate kinases will show up. Okay, not directly from the sugar to the monophosphate. Monophosphate to diphosphate is the kinase. And then there is a common kinase called NDK that will convert any GDP, any diphosphate to the triphosphate. Okay, but here is a relevant part for us. So basically the cellular kinases will convert GMP to GDP to GTP like here. And this will get incorporated in DNA or RNA and damage it, and the cells will die. That's the principle. But what happens is that in most of us we have this protein called NAD-T15. So NAD-T15 hydrolyzes GTP back to GMP. This GTP back to GMP. So because of that, it keeps relatively low levels of 6-thio-GTP. And is it making sense? Right? If this is absent, or if it is not functional, or if it has very little activity, then these guys accumulate. And if they accumulate, they will kill the normal cells, and it will create so much toxicity that the person may die. So you are giving a simple leukemia drug, and that can actually prove fatal if NAD15 is missing. So NAD15 breaks down toxic thioguanine triphosphates to the corresponding monophosphate. If NAD15 levels are low, then there is huge bone marrow toxicity. Okay. Now this is another example, another enzyme, TPMT, thiopurine S-methyltransferase. So remember this one here, this compound azati, and this one here. So it takes this 6-mercaptopurine and it methylates it. Okay. So because of that, it keeps the level low of this compound. If 6-TMP, so it inactivates thiopurines by methylations and clears it from the body to maintain low level. If this is not working, too much of TGN accumulates, and if TGN is accumulating, basically too much bone marrow toxicity. Go ahead.
These two enzymes are produced by your body, or it is administered?
No. It is, you mean the compounds or the enzymes?
Enzymes.
Oh yeah, we have it. I will show you actually. I have a very interesting slide here. Okay, so just give me 1 minute. I'll come to that, and that will actually show you who expresses it and who does not express it. Okay, so if TPMT or NAD-T15 is deficient, less activation, excess TGTP build up, thio-GTP build up, bone marrow suppression, which can have a severe consequence. Okay. So these two, both of them lead to bone marrow toxicity, neutropenia, anemia, and all of these things. Okay. So look at this. This answers your question. So TPMT, most common in Europeans and Africans. Okay. NAD15, more common in Asians and Hispanics. See, it is totally ancestry based. Totally ancestry based. So TPMT deficiency fails to inactive 6-mercaptopurine early. That leads to myelosuppression. So what you have to do? You have to reduce the dose. So if you have to give this dose to a patient with leukemia, you have to give low dose, otherwise the toxicity is going to be too severe, because whatever little dose will get converted to TTP, right? But then it will not be cleared. So you have to give really low dose. NAD15, this is even stronger thing. So you reduce the dose, so rapid severe early neutropenia, so you reduce the dose even more. So keep in mind, for this leukemia, it is absolutely essential to do a genetic testing before you administer this drug. Okay. Poor metabolizers due to TP-MTR at extremely high risk of life-threatening myelosuppression with standard thiopurine doses. I'm sorry. And require drastic dose reductions. Okay, so there are, high metabolizers, intermediate metabolizers, and then very low metabolizers. If you have one or the other deficiency, it's bad, but if you have the deficiency for both, it is extremely bad. Then you have to give really tiny dose. Okay, and we are talking about leukemia here. So you have to give the drug. So the drug itself is toxic, and then the dose can really be very important here. So it can be poor metabolizer with two loss of function, not T15 variant, have absent or intermediate metabolizers, and poor metabolizer are at very high risk of severe myelosuppression and require drastic dose reductions. Okay, intermediate are obviously also, but they have to be given intermediate dose, lower dose. Okay, so combined, if both of them are there, then it is extremely severe. Okay, all right. So that is why all these consortiums, okay, they have recommended pharmacogenetic testing for these things. So before you give this drug, you have to do the testing. Okay, so genotyping results guide a patient's starting dose and help mitigate the risk of severe toxicity. Okay, so okay. Second thing is the drug transporter. So that was metabolism, right? This was metabolism. One drug was getting metabolized, the other one was not getting metabolized, cleared. The second thing is drug transporter. So some people, they express huge number of transporters. So what are transporters? You give the drug and they throw it out of the body. So these are efflux pumps. They throw the drug out of the body. And these are ABC transporters. So if they're throwing the drug outside the body, outside the cell, you have to give higher dose, right? Because they keep throwing the drug out of the cell. It will not have the therapeutic effect. Okay, so go ahead.
So these drugs are captured by some enzymes and then they are effluxed out?
No. Just give me 1 second. So most of these drugs are cell permeable. So you give them, that's why it is showing you it is lipophilic molecule. It comes inside, and then what happens is that in response to these drugs coming out, these efflux pumps either are already present or they are going to be upregulated, and then they will efflux the drug out. So many cancers, you give the drug initially and they have very good response, and after that they stop responding, and it could only be due to the upregulation of these efflux pumps because they are just throwing these out. One time back in 2001, when gene chips were just made, so the director of our institute was the one who made it. So it was not even commercially available to other people, but we had it in our institute. So I added a very simple compound, a purine-based inhibitor, and we did gene chip thing. The first thing which came up was a drug efflux pump. You treat them for just a few hours and efflux pumps are upregulated to throw it out. So that is a natural response, and in cancer that is very prevalent. So the intracellular drug levels will obviously go low, but it can be inherent. It can be an inherited thing, so that there are more drug efflux pump. Okay, so reduced efflux activity, that means more drug is going to be there, so you can have lower dose. Higher efflux activity. Other polymorphisms are linked to higher PGP, is that efflux pump's name, expression or enhanced activity which more effectively pumps drugs out of the tumor cells. So the drug's effectiveness is reduced, so you have to give them higher dose. Okay, and many times they do not fold properly or something, so accordingly you have to decide the drug dosage. Okay, now so this is a major cause for drug resistance, upregulation of these efflux pumps. Okay, so breast cancers, so this is the same, PGP1 is the same as ABCB1 thing. So many studies have explored the association between these efflux pumps and breast cancer outcomes, and so when you have upregulation of this drug, and paclitaxel is a chemotherapy drug, right? So paclitaxel is a very important chemotherapy drug, but if this efflux pumps are out, those patients do not respond to paclitaxel therapy and they die much earlier. So it's very poor prognosis. These efflux pumps are upregulated, poor prognosis, because the drug is not going to work, okay, because it will be thrown out. See, in leukemia, if the pumps are highly expressed, it causes resistance and poor patient outcomes. Yes.
What are the reasons behind it that the efflux pumps are getting activated during the drug?
So it could be a germline mutation that they express this thing. It could be inherently in that person. Second thing is that it is also upregulated in response. So you know the way our body is built, a lot of foreign things come in our body, so it's a natural response to get it out of the thing. So this was built to protect us from that. But when we are taking the drug, the body actually doesn't know whether it is good or bad, right? It is a foreign thing. So its natural response is to upregulate the efflux pumps. That's what I was saying, even in the cells, right? These cells, it's not a human body, it's not an organism. You add that inhibitor, efflux pumps just are turned on.
What do, like, efflux pumps are ultimately a channel protein, so what do those proteins exactly look for in a molecule to pump it out? Is there some specific, or is it just
There are some specific, there are many different kinds of pump, but they are not 100% specific, otherwise they will keep on changing, right? So they are pretty generic. They take it, they use ATP energy, they just throw it out.
I was thinking in the sense that if we could change the conformation of the drug that we are delivering, so that maybe
they are too smart. The more complicated drug you make, they will throw it out. Yeah. But then, you know, the way to overcome that is that you use PGP1 this PGP pumps inhibitor. You give the drug and you use those inhibitors, then they cannot pump it out. You give them something which they like more, they are shut down, right? Ovarian cancer has the same thing, okay? Upregulation, chemoresistance. So pharmacogenomics improves treatment efficiency, it reduces adverse drug reaction, and you can personalize it to a person, okay? If challenges are obviously, if there is no facility to do genetic testing in some region, that could be limiting. And you know, for many drugs we know that these are the pumps and we do genetic testing. But suppose in Asian, in Native Americans, right, testing have never been done, so we don't even know what kind of mutations exist there, so we don't even know what to look for. So these people may suffer who have not been included in clinical trials, right? Because most of studies are coming from European ancestry people, okay? And it is obviously a little bit expensive, not that expensive because it can be tested by PCR, but it has a higher cost of implementation. Wow.